Hello, everyone, and welcome to the medical track and our panel on substance and medication use and its impact on driving, something most of us do every day. I'm Mary Maguire. I'm Director of Public and Legislative Affairs at AAA Northeast. Any AAA members in the room? Okay, great. Hopefully you don't need roadside assistance too often. Hopefully you're taking advantage of the discounts and the other good things. We are looking forward to a very interesting, lively, spirited, provocative discussion this morning. I can tell you that our presenters have some very provocative material that I was very much struck by, and we think you will be too. And we will have plenty of time for questions and comments after the presentations, so we invite your questions then. I will introduce our distinguished panel members in just a moment, but first, a few words on our topic today. One thing is clear, a growing number of Americans are driving under the influence of some type of drug, whether it be a prescription drug or medical or recreational marijuana. A recent survey tells us that 70% of Americans take at least one prescription drug. More than half take two prescriptions, and 1/5 of all Americans, roughly 20%, take 5 prescriptions or more. I think that's a pretty startling statistic, but certainly when we're talking about senior drivers, not uncommon at all. At the same time, more than 20 states now, including all the New England states, have legalized the use of medical marijuana, and 4 states, Alaska, Colorado, Oregon, and Washington state, have voted to allow recreational use, with Massachusetts and Maine considering it. So some of the questions are, what is the impact of driving under the influence of prescription drugs? How do multiple prescriptions interact with each other? What effect does marijuana have on driving? While many claim that driving under the influence of cannabis doubles the crash risk, many unanswered questions remain. And while field sobriety tests can measure impairment and blood alcohol content, it's often far more difficult to gauge the impact of marijuana and prescription drugs and other substances, and there are many, on driving. With us now to discuss these very complicated and timely issues is our distinguished panel. I think we can safely say that Michele Matthews is an expert on pain. Is that correct? Reading your bio, and here's why. Dr. Michele Matthews is an associate professor of pharmacy practice at MCPHS University in Boston and practices as an advanced pharmacist practitioner in pain management at Brigham and Women's Hospital. She participates in team-based care of patients with chronic non-cancer pain at the Brigham and Women's Pain Management Center. Michele has also implemented a pharmacist-run chronic pain management clinic within the hospital's primary care center, where she has prescriptive authority under collaborative drug therapy management for patients with various chronic pain syndromes. Dr. Matthews additionally works within a collaborative care model as a care manager to improve the management of opioid abuse and alcohol dependence within the primary care setting. Dr. Matthews is a certified pain educator and a board-certified ambulatory care pharmacist. She actively conducts research on the role of the pharmacist in the prevention of medication misuse in patients with chronic non-cancer pain and is a co-investigator for a Center of Excellence in Pain Education grant, which is awarded by the NIH, and congratulations on that. So I told you she was an expert on pain and medication as it relates to pain. Please say hello now to Michele Matthews.
Good morning, everyone. Thank you so much for that introduction. So for those of you that watch AMC, you kind of have a hint of where I got this title from, probably one of my favorite TV shows of all time. And really the purpose of today's session, at least for my portion, is to provide you with a topical review of how medications fit into safe driving. So I'm going to highlight for you one of my patient scenarios, and the patient that I'm going to present to you is an actual patient that I've been working with for several years now, and talk about how this particular patient's medication profile might place her at risk for some safe driving issues, and give you an opportunity to kind of really comprehend the nature of these prescription medications, especially when we're talking about illicit drug use in combination with them. So we're going to talk about some factors that affect drug response in older adults, list the medications and substances that can impair driving and list their common side effects, and identify methods to improve driving safety in older adults. So here's my patient. This is Gigi. She's a 68-year-old woman who presents to her primary care doctor for follow-up, so I do work with her within the primary care clinic. She has a history of lung cancer, which is now in remission, chronic low back pain, which is what I'm treating her for, chronic kidney disease, hepatitis C, osteoporosis, urinary incontinence, anxiety, and depression. So she has a lot going on here. She has multiple medical comorbidities, which already is placing her at risk for being prescribed multiple medications. Her husband just bought her a new car. Prior to this, she was not driving, but now that she's retired and they're heading into the golden years, she is looking at being able to drive around town and to some of the other more beautiful areas of Massachusetts and enjoy the rest of the time that she has ahead of her. So let's talk about her medications. What I tried to do just to make sure that I'm leveling the playing field in terms of everyone's background knowledge related to healthcare is separate her medications out by her disease states. So we'll start off with her depression. She's managed with a medication called Wellbutrin, which is very commonly prescribed. It is a very common antidepressant that we use in practice, and it's also was not as effective as we were hoping that it would be, so it's been augmented with a medication called Abilify, which is an antipsychotic medication. She also has a history of osteoporosis, where she takes calcium and vitamin D, obviously recommended for mostly everybody after the age of 30, as our bones start to break down after that age. Anxiety, where she's managed with diazepam, 10 milligrams, which is a relatively high dose, which she takes multiple times a day. Chronic pain, which I'm managing, which we're prescribing gabapentin, 1,200 milligrams by mouth 3 times a day, ibuprofen, and then also she has a history of urinary incontinence where she's prescribed a medication that helps with those symptoms. As we're discussing her medications, she does bring up the fact that she has been drinking 1 glass of red wine each night with dinner and admits to smoking marijuana on occasion for chronic pain and anxiety. So when we review her system, she tells us that she has blurry vision, her balance is often impaired, her memory is often impaired, that she has constipation and decreased ability to urinate. So what I want you to think about for a minute is, based on what I'm sharing with you, what medications might be contributing to her current symptoms? What are the effects associated with combining her prescription medications with alcohol and marijuana, and is it safe for her to drive? So before we go any further, how many of you think it is safe for her to drive? Right, by a show of hands. Okay, good. All right. So before we go into the individual medications that are concerning in older adults, I want to talk about how the body changes as we age and how that affects the effectiveness or the safe use of medications. So we're going to start up here in the central nervous system in the brain. So as we age, we start to have an increased sensitivity to cognitive impairment. So we're not thinking as clearly as we were in the past. We also become more sensitive to sedating medications. We also know that there are less binding sites for drugs in the blood, and what that means is that the less that the drug binds to certain places, the more drug that's available to actually go off to other parts of the body and have some sort of effect, typically an unintended effect that we're not looking for. We also note that there's less volume of distribution, and what that means is that there's more drug available in the blood. Certain drugs like to navigate and kind of move through the body and deposit in areas like fatty tissue. We know as we age, we start losing that fatty tissue and we have more lean mass. So there's more drug available, again, to have a bad effect. We have slower drug metabolism. Drugs are chemicals. Our liver needs to detoxify these medications. So if our liver is not working as well, it's going to take longer for these medications to be detoxified and then eventually eliminated, which also is impaired because our kidneys don't work as well. And our kidneys are our primary way of filtering out these chemicals and toxins. Additionally, older adults are at a higher risk of having drugs cause actual kidney damage, whether that's acute kidney impairment, any sort of renal impairment, which could be prompted even by something such as ibuprofen in the right patient. We also note that there's decreased absorption of the medication, so medications when swallowed, so taken orally, they may not be as absorbed as well as we would like them to be. Our guts don't move as fast, so we call that delayed gastric emptying. So the more that a medication actually sits in your stomach, the higher the likelihood of it being absorbed into your bloodstream. And that also places patients at risk for other complications, which would include gastric ulcers and constipation. We also have decreased muscle mass, increased body fat, increased bone loss, increased thinning of the skin. All of those things actually can affect absorption and distribution of medications, which is important because some medications are applied on the skin. So if we're applying a patch medication on a patient and their skin is thinner, they're likely to get more of that medication into their bloodstream. And I had mentioned earlier about fat and muscle. As we age, we lose that fatty tissue, and that's a place where medications tend to deposit. So there's less space for these medications to go, more room for them to stay in the blood, and again, have an unintended bad effect. So now we're going to highlight the prescription medications that can impair driving. And a lot of the medications that we're going to be talking about are things that are on the top 200 drugs list. So this is a list that we educate our pharmacy students on. From a fiscal perspective, these are the medications that have been making the most money within the United States. So let's start off with the first one, barbiturates. These are medications very commonly used for headaches and migraines. You may know them as Furoset and Furanol. These medications, unfortunately, are very commonly prescribed in older adults. Up until a couple of years ago, I'd say one of the #1 medications for pain and headache in an older adult was something called Darvon or Darvocet, which is fortunately no longer available on the market because of the cardiotoxicity that it had caused in the past. Then we'll move on to our benzodiazepines. These are medications that are used for anxiety, sometimes for sleep, sometimes before we have to go in an MRI, and we don't like that, so it helps calm us down a little bit. We have medications like Xanax, Klonopin, Valium, and Ativan. Now, these medications all have very similar ways of working, but they have very different chemical characteristics. So, for example, Valium, in a normal, healthy adult, if taken one dose, can actually hang out in your system for more than 30 days. And that's because it likes fatty tissue. So what it will do after you take it is it will be absorbed, and then it will just kind of deposit and then re-release itself into your body as time goes on. Now, as an older adult, you're losing some of that fatty tissue, and you're getting all of that medication in the bloodstream. So you may have more toxicity and more sensitivity to that medication, but it may not last as long as someone who's a little bit younger. Some of these other medications like alprazolam and even lorazepam work very similar to diazepam, but they don't last as long. So there's some differences in their chemical composition and also how long they have activity in the body. We also have medications like sedative hypnotics. These are very commonly prescribed. If you look at the bottom of that list, a medication called Zolpidem, which is the brand name Ambien, is actually in that top 200 drugs list. And this is a medication that more recently has been associated with some adverse effects, including sleepwalking and also sleep driving. So let's look at what these drugs can do. And we're thinking about this in the context of driving. They increase your risk of sedation, which is what we want in most of the cases, right? We're using this for anxiety, for sleep. We want the person to be tired. But it also results in diminished coordination, weakness, clumsiness, loss of balance, distorted vision, and as I mentioned earlier, sleep driving is something that we're starting to see with these medications. So that has prompted us to say, well, maybe these are not the best options in older adults. And I think we live in a society where it's very easy to prescribe a medication and kind of listening to the last presentation, not really focusing on the non-drug options for improving sleep and improving anxiety. And thinking back to this patient is on diazepam. So I'm just going to highlight as I go through the classes of medications, all of the medications that this patient is taking that actually could put her at risk for impaired driving. The next class are the antidepressants and antipsychotics. So I mentioned earlier that this patient is on 2 of those medications. These are very commonly prescribed medications. We have medications that are sometimes not only used for depression, but they can also be used for pain. So Cymbalta, you may have seen commercials for that particular medication. And then you also have the antipsychotics, and these can be used for very severe mental health issues, or like I mentioned earlier, in patients with severe depression that are not achieving appropriate outcomes, we can add antipsychotics to the regimen to help augment it and improve their outcomes. These medications have a very similar profile to what we just talked about with the sedative hypnotics. Increased sedation, diminished coordination, decreasing blood pressure. So that could be alarming and concerning in an older adult because our body doesn't compensate the right way. If we get up too quickly, that can cause us to faint because our blood pressure drops too low. It can cause tremors, and that can have an effect on steering. Altered sleep architecture. So this will affect the sleep-wake cycle, visual disturbances, and confusion. And thinking back to this patient, there are 2 medications that she takes from this grouping. So again, we're adding this to the fact that we already know that she's on a medication such as diazepam. Moving forward, let's talk about some of the medications that I use very commonly in my chronic pain practice. Anticonvulsants. So although their name says they should be used for seizures, they're very commonly used for patients that have nerve pain. And gabapentin, being probably one of the more commonly prescribed medications for nerve pain, has a lot of cognitive impairment associated with it. Also topiramate, which is called Topamax, which my patients refer to as Dopamax, because it makes them feel really dopey and loopy when they take these medications. Muscle relaxants. So for those of you, I'm a child of the 80s, so one of my favorite movies was 16 Candles. The wedding scene where you see the bride walking up the aisle, she can barely keep herself coordinated. So that's what I think of when I think of muscle relaxants. They're very powerful medications. They cause a lot of sedation. Then you have a medication like carisoprodol, which we also know as soma, which actually is metabolized and broken down in your body to a barbiturate. And a barbiturate is a sedative. So if you have a patient taking this for muscle relaxation, they're also at risk for having some of the effects of taking a barbiturate as well. We have our antihistamines, Benadryl, Vistaril, very commonly used, but probably inappropriate in older adults in general, never mind someone that's driving, because they're very sedating. We have newer alternatives, things like Claritin and Zyrtec and Allegra, that are all available over the counter that are a lot less likely to cause that type of effect. So these medications, similar to what we've mentioned, increase sedation, slowed psychomotor function, so the brain is not connecting the right way with the body movements. Sleep attacks, where the patient just passes out. Dyskinesia, so distorted movements, blurred vision, and impaired balance. And again, back to this patient, she's also taking gabapentin. The medications that I probably work with most commonly in my practice are opioid analgesics. These are medications that we hear a lot about in the news these days because of the epidemic of prescription opioid abuse that we have. And the older adult population is not protected from that. I do see opioid abuse and misuse in older adults as well. So I do want to highlight that all of these, anything from even Suboxone, which we use for addiction, all the way down to something like Tramadol, which I often hear clinicians and even patients say, oh, it's not as strong as other medications like morphine or Percocet, but it can be when you mix it with these other substances or you take them with other prescription medications, especially anything that works within the brain. So increased sedation. One of the most important things with opioids is that they tell your brain to breathe less often. So that is really important for us to pay attention to in older adults who may have very severe pulmonary issues, COPD, other patients that might require extensive treatment for respiratory issues. They cause fatigue, lightheadedness, and also vision changes. So I want to switch gears a little bit, and I don't want to just focus on the medications that work for depression and chronic pain and muscle relaxants. I also want to point out that there are medications that are used very commonly as maintenance medications for chronic diseases that also can place patients at risk for driving issues. So antihypertensives, I mentioned earlier that if your blood pressure starts to drop too low, obviously that can cause complications. Same thing with anti-diabetic agents. These medications will start to lower your blood sugar, and when we start to get hypoglycemic, we have consequences and sequelae associated with that. So there's fatigue, there's confusion. Intestinal agents, so these medications can contribute to, again, more sedation, placing patients at risk for constipation as well. So dizziness, lightheadedness, drowsiness, blurred vision, and delirium are all very common. So a lot of the side effects that I'm mentioning are not things that are small risks. These pose a very high risk in the older adult population. So those are the prescription medications that are commonly implicated in impaired driving. Now let's shift gears and focus on over-the-counter. So when I say over-the-counter, that doesn't mean that it's safe. So the majority of the medications that are available over-the-counter are not regulated the same way that prescription products are. So many times if you're grabbing a supplement off the shelf, there's really no guarantee of the quality or the actual dose or the ingredients within that supplement. So there are certain things that are relatively safe. These would be the antihistamines. I've talked about a lot of these already. Plus, you're also seeing an increase in the availability of these over-the-counter sedatives. So you have ZQuil, which is probably the newest one that I've seen recently. You have Unisom and all the generics that are made by the companies out there. You have medications like meclizine, which is often used for seasickness or nausea, and vertigo, which is also very readily available over the counter. We have our analgesics, so these are their pain relievers. We have Tylenol PM, Motrin PM, Aleve PM. Basically, these are all over-the-counter acetaminophen or ibuprofen that they add diphenhydramine to. So it's basically Benadryl or something similar to Benadryl that's been added to these formulations. All of these medications can cause sedation. Now we have our sedatives that are considered to be more herbal products and supplements. We have chamomile, kava, lavender, melatonin, St. John's wort, valerian, also very commonly available in tablet form, also in teas. right? So a lot of the patients that I work with, oh, I just drink a tea to help me sleep, and not really think about the ingredients that are in there. So I really encourage the patients that I work with to make sure that they're reading the labels of anything that they're purchasing. So when looking at alcohol effects on driving skills and in certain road tests and simulated road experiences, they have found that there are alterations in concentration, judgment, comprehension, coordination, vision and hearing acuity, and reaction time. So all of these things are concerning, and this is just alcohol by itself. We're not talking about alcohol being mixed with other substances. When you mix alcohol with prescription medications, this is what we end up seeing. There's an increased risk of sedation, dizziness, slowed breathing, impaired motor control, and most importantly, increased risk of overdose. So most of the people that end up overdosing on substances, more than 50% of the time are co-abusing substances. So it's usually not just alcohol by itself or Percocet by itself. It's Percocet plus Ativan, or it's alcohol plus a medication that maybe they didn't realize was going to mix poorly. So the three classes that we really have to be on the lookout for, especially in this population, benzodiazepines such as Valium, opioids such as morphine, and muscle relaxers such as Soma. The other ones that are also concerning but can be monitored and managed would be antidepressants and antihistamines. Now let's switch gears a little bit and think about marijuana. So I am by no means an expert in this. It comes up a lot in my clinic now that there have been some legislative changes, which I'll mention very briefly. But in simulated driving tests, there have been alterations in reaction time, perception, short-term memory, attention, and motor skills. And there's a concept called crossfading, where you're co-abusing something that's supposed to bring you down with something that's supposed to bring you up a little bit. And they find that in simulated tests, performance impairment, impaired judgment, and some studies have actually suggested a cancellation of effects. So I wouldn't be promoting that information to anybody. Obviously, there's more research that needs to be done, but these are very controlled environments, and in most scenarios, people are, as I mentioned previously, using multiple substances at one time in very inappropriate ways. So I don't want to go through all the legislative information related to this. I'm happy to send you my slides if you'd like, but I do want you to be aware that medical marijuana has been approved in Massachusetts under very clear circumstances. And there are some aspects of the law that it does not allow for, which would include operation of vehicles, having coverage by a health insurer. So that comes up a lot. Well, if you stop prescribing my pain medication, will Harvard Pilgrim start paying for my marijuana? So there's a lot of discussion related to this too. So I think it's important for us to know the law and for us to share that with our older drivers. So just to wrap up, I'm getting the hook. Is it safe for Gigi to drive? By show of hands. So I think we made a really clear case here that it's completely inappropriate for her to drive. So how do we deal with this patient? So this comes up a lot in my practice. So we have to talk about the substance abuse. Let's talk about how we can get her to limit her alcohol and marijuana use. Then as a pharmacist and working as a healthcare provider, working with how do we modify this patient's regimen? We can probably cut back on the doses of certain medications. We can adjust the timing and frequency. We can encourage non-drug ways of managing medical issues, especially for chronic pain, where I try to minimize the importance of medications and emphasize the importance of physical activity and other behavioral health changes. Change medications that cause impairment. So if a patient's on Benadryl, talk about switching somebody to a non-sedating antihistamine. I monitor, or we need to monitor these medications closely. And lastly, there needs to be alternative forms of transportation. So in summary, many common, so not things that we rarely see, very common prescription and over-the-counter medications can impair driving. Obviously, that risk is significantly increased when combined with other substances. We need to make sure there's an open dialogue about the prescription and non-prescription medications and try to ensure proper access to transportation for these patients, especially if the benefit outweighs the risk of them being on particular medications. So thank you very much. Apologize if I went over time.
Thank you, Michele. That was terrific and very eye-opening. Show of hands, how many people were surprised by the number of medications that Gigi was taking and the fact that she was also drinking wine and smoking some marijuana too? I was pretty shocked when I read the presentation and I asked Michele if it was something she had made up, and she said it's actually commonplace among her patients, which was also pretty startling for me. So, my friend Lieutenant Stephen Walsh, Massachusetts State Police Lieutenant Stephen Walsh has 35 years of law enforcement experience. During that time, he has focused on the performance and administration of traffic investigations, enforcement, and highway safety initiatives. Steve is an Army veteran and holds a master's degree in criminal justice. As Chief of Staff to the Commander of Field Services, Lieutenant Walsh has been responsible for developing policies associated with highway safety mobilizations. As the NHTSA liaison to the Mass State Police, Lieutenant Walsh procured and managed grants and was involved in the training, operational planning, deployment, and reporting of the state's highway initiatives, including the highly successful Sobriety Checkpoint program. He has also served as the liaison to several private and public partners, including MAD, AAA, the National Safety Council, CARE, and the State Strategic Highway Safety Plan. Lieutenant Walsh's efforts helped his department win a number of awards. As a trooper and as executive officer to the Collision Analysis and Reconstruction Section, Lieutenant Walsh conducted and supervised thousands of fatal crash investigations and prosecutions. Steve is currently the commanding officer of the Andover State Police Barracks, and he was recently the operating officer overseeing a 2-year distracted driving pilot, which got a lot of media attention. Steve has been a great friend to AAA over the years. Please give him a warm welcome. By the way, can everybody hear in the back? Everybody in the back able to hear? Okay, terrific. Go ahead, Steve.
Having just turned 60, I'm very sensitive to this elder driver. I don't know quite where it falls, but I suspect I'm approaching that. So I looked into it, and I looked back on my past. I did reconstruction for many years, 24 years to be exact. Thousands of fatal crashes I either investigated or oversaw, and I look back at some of the ones that involve these elder drivers, and I can remember more than a few occasions something to the effect of the harder I stepped on the brake, the faster the car came up. Another common theme was, well, I drive this way every day and never had a problem. Well, until the pedestrian walked out in front of you. In fact, the very first fatal I reconstructed was in the city of Newton, and it involved an elderly woman got stung by a bee, drove up on the sidewalk, and killed a young girl on a walk. So I guess I have had a lot of experience with the end result on this. And one of the things I found in looking at this, I'm not sure if we have police experts in this field, because I think Massachusetts is a little behind the times in police training on this. So the bottom line is, you've heard a lot of statistics today. We're going, if we don't already have, we're going to have a lot of elderly or older drivers in the near future. And I'm not going to get into the politics of this, but particularly in this state, we have an issue where there's no administrative oversight that has any control over this to a large degree. As far as I know, the only limitations are when you're 75 and older, you have to take a vision test at the Registry of Motor Vehicles. Let me give you a little disclaimer. Everything I talk about today is not specifically focused on older or elder drivers. These statutes and the policies I talk about apply to all drivers in Massachusetts. And let me give you the ending at the beginning here. Massachusetts law enforcement in general is ill-equipped, training and legislatively, to deal with elderly drivers on the roadway. So how does law enforcement encounter an elderly driver on the roadway? Well, the most obvious is motor vehicle crashes. Next is violations of law. And then there's There's when they come up and they ask you for directions, when they're lost. There's a multitude of ways that you can imagine that law enforcement does come into an encounter with an elderly driver. So, the officer on the street is forced to make a roadside assessment based on what he's presented. Is the elderly driver seemingly diminished capacity the result of cognitive impairment, Alzheimer's, dementia, or drugs, medication? Alcohol should be in there. Actually, let me give you a little personal experience, because I do have a little more experience than most. I have a mother with dementia, and I have a mother-in-law living with me with dementia, so I'm acutely aware of what dealing with someone with dementia entails. So there's roadside assessment. We have to determine, if it's one of these things? Or do they have physical limitations that prevents them from driving safely? Or is it all of the above? You gotta remember, we're roadside. If you're lucky enough to be in the city or town, perhaps you're in a safer place than the breakdown lane of 93 at 2:30 in the afternoon. Is the operator OUI? OUI is kind of specific to this state. You'll find, for the most part, DWI, driving while intoxicated, DUI, driving under the influence is used. I'll stay with the OUI. It's become an acronym we're used to. So Joanne's going to go far more into detail in the laws, but I do want to touch on one thing, and this falls right into the doctor's presentation. The laws in Massachusetts for impaired driving are operating under the influence of alcohol, marijuana, narcotic drugs, depressants, stimulants, vapors, or glues. I was going to throw this out, but let me ask the doctor. Are there any medications not on this list that affects people's ability to drive? I suspect there's a lot, okay? Impaired driving is not necessarily illegal in Massachusetts. Okay? You have to fall into one of these categories in the impairment. Here's another obstacle we encounter roadside. Standardized field sobriety testing is sponsored by NHTSA. It's a national standard for conducting standardized field sobriety testing in a proven methodology with statistics to support the results. In some cases, it's even international. It does not apply to someone that's 65 years or older. I'm 60 years old, okay? It's not that hard to conduct these, but you're going to get crucified in court if someone is over 65 on these. So what do we do? You know, I tend to think we're not putting an 85-year-old woman out in a one-leg stand in the breakdown lane, but we have to determine, are they impaired? Is it cognitive? Is it physical? What are we going to do with them? So how do we develop probable cause? We're talking probable cause for the arrest now. Well, one of the up-and-coming things we have, and this state is behind the times on this, is drug recognition experts. These officers go through a pretty intense training. It's a 2-week training followed by a few days. Generally, they go to Arizona, the prisons down there, because they can encounter a large degree of various people under different drugs in a very short period. So they're trained to determine if someone is under the influence and then hopefully what category of drugs they're under the influence of. It generally requires some cooperation on the part of the person. This generally isn't conducted roadside. It usually happens after the arrest. So what are our roadside options here? The obvious on the impaired driving, if they meet one of those categories and you can develop probable cause, is arrest. Now, given the complications, I'm sure we have some police officers out there, given the complications of establishing your probable cause, given the empathy factor that you can't take away, how often is this going to be the result? Probably less often than it should. So what are our next options? This is something I suspected, and I had to do a little research to come up with it. Absent a right of arrest or a equipment violation or some other reason to tow that motor vehicle, we have no statutory authority to take someone off the road just because their ability to operate, in our opinion, based on our training and experience, is impaired, or not impaired, it is diminished, I should go with. So where do we fall? The best answer I can get out of this are some of the obvious answers. Again, it works very well probably in a city or town, not so well on the breakdown lane of 93. Call a family member or friend. Hopefully you get a sympathetic voice on the other end of the line that wants you to deal with a situation. And I would suggest that's probably more often the case. Call medical services. Hope that they can deal with the problem. It may be a medical refusal and you're right back to square one. So this is the best answer I can come up with on this. Police have a caretaker function. We use this in quite a few situations. And I think 99% of the time, this is going to be sufficient. We have an obligation to the public and obligation to the person that we've encountered to make sure they're safe. So more often than not, we're falling on this. We're going to call family or friends. We're going to transport the party to another location, maybe their home, maybe a family or friend home, and we're going to impound the motor vehicle. What happens to the 1% of the time when no one was in agreement with this? The family felt we had no reason. The person driving felt they were fine driving. Okay. Sometimes no good deed goes unpunished. Again, there is no legislative authority to impound that vehicle, or essentially you're seizing that operator by taking them off the road. Here's the good news. It gets a little better for us post-roadside, okay? We've now gotten them off the road by whatever means we can. And we have the registrar's authority under 9022, and if you were in the other presentation, Mary and Ryan spoke of this, request for immediate threat. These are very effective. They require a violation of law, and a police officer fills out the affidavit, which will be coming up, I think, on the next slide. The registry, in my experience, takes immediate action on these. The license is generally yanked the next day or the day that these arrive. It's not indefinite. There's a right to a hearing on this, so you're not the judge and jury out on the road. The next option, Doctor, I suggest Gigi should have gotten one of these, is a request for medical evaluation, but this also includes law enforcement as well as the medical side of the house. This isn't an immediate situation. This is where you file a request with the Registry of Motor Vehicles indicating your probable cause or probably just reasonable suspicion will do on why the person should no longer be operating a motor vehicle. And this is the immediate threat form. And you'll see that you're signing to an affidavit listing the actions that you observed and why you feel the individual should no longer be driving. These also apply to negligent operation in the form of someone perhaps with a horrendous speeding record or multiple violations. Could be a younger adult, it could be a teenager. But it's very effective for an older driver. Personally, I can remember filing one of these on a woman that blew through a red light, had absolutely no idea where she was going, and I remember driving by her house several times wondering if she was eating cat food because of me. And here's the medical form. As you'll see, it can also be sent in by a law enforcement officer, and again, you're articulating your observations and your reasons why you feel this person needs to be evaluated. Doctor, have you seen these? Are these typically filled out by medical? Yeah, I suspect these are not used to the degree they are. I think probably people have relationships with their family doctors, and the doctors may not be the ones that want to step in until the family approaches, which, by the way, the immediate threat is not the appropriate form when the family comes to a police officer and says, I need to get my mother-in-law off the road. Can you file an immediate threat? You have to have a violation of law. So the police officer would have to fall back on this form. I wasn't familiar with this National Association of Triads. We have some police officers here. Anyone familiar with this? Anyone's department use this? Okay, this is a conglomerate from what I can gather with AARP and other associations. Maybe AAA is part of this. You ever heard of it, Mary? No? Okay. Anyway, at the police level, what they're doing, and I really like this idea, there's an officer assigned to the department that is reviewing crash reports, reviewing incident reports, perhaps taking verbal accounts from officers on the street of encounters with elderly operators, and they are taking action with the registry for these at-risk operators. So what are my recommendations? I think we need the assessment of older drivers to fall on the responsibility of law enforcement, medical professionals, the registry itself, family members, and I don't think we can take away the responsibility of the elderly operator themselves. On the police officer end of it, I think, and currently there is no curriculum in the police academy or in-service level to deal with elderly operators, specifically for that. We need to learn to recognize the cues that indicate a driver's cognitive and physical limitations, develop a strategy to identify these at-risk drivers, document encounters with at-risk motorists. If it's not written, it didn't happen. You've all heard that. And then refer these at-risk drivers to the registry through the immediate threat, or probably more appropriately is that medical form. And then serve as a resource officer, and I think that's probably what these internal officers are doing, is they're working with the family and providing alternatives to that person driving, maybe. I think I'm extending my time here a little bit, so it's been a pleasure talking to you all, and I'm available if anybody wants to speak later on.
Lots of great suggestions for change coming out of these panels today, by the way, and more great recommendations from Steve, who, by the way, looks great at 60, doesn't he? And happy birthday if it was recent. It was, okay, so happy birthday. So Steve deals, as he's told you, with Michele's patient when she gets on the road with her new car that her husband gave her, and our next speaker takes it even a step further. Joanne Thomka is director of the National Traffic Law Center of the National District Attorneys Association in Alexandria, Virginia, and she came all the way up from Virginia to be here today, so we appreciate that. The NTLC provides technical assistance, legal research, and training support to prosecutors, law enforcement, and other traffic safety professionals across the country. She was formerly a senior district attorney for the Onondaga County District Attorney's Office in Syracuse, New York. Director Thomka was the bureau chief of the DWI unit from 2000 to 2006. Ms. Thomka was previously a member of both the Special Victims and Violent Felony Bureaus within the Onondaga County District Attorney's Office. Joanne is a former president of the Onondaga County Bar Association, has won numerous awards, sits on several traffic safety committees, and teaches at legal seminars and events like this one across the country on impaired driving and vehicular crimes prosecutions. Please welcome Joanne Thomka. And I get a special award for saying Onondaga 3 times, sort of correctly. Onondaga.
But 78-year-old man drinking at his American Legion or one of those clubs up in Syracuse, and he'd been drinking all afternoon and decided, okay, it's time for me to go home after I've had all these beers and whatever else he was drinking. And as a woman was getting out of her car, parked on the side of the street, going around the front of her car to try to go get her child out of the back, he came plowing beside her, couldn't judge distance, had very little perception reaction time, took her out, took out her door, and crushed the entire lower portion of her body. Sent her about 75 feet where she landed and was basically impaled on the door that was also taken off. I'm going to tell you I had no problem prosecuting that man and sending him to jail. Okay? He knew better. And we're the people in this room that are dealing with our older drivers and are being responsible for the messaging we have to send to those older drivers in our community. That age and voluntary impairment and voluntary lack of education about the medicines they're taking, or this prescription, as they're calling it, marijuana, which we all know a physician cannot prescribe a Schedule I drug. We have to message back to them. It's your responsibility to know. Age is not going to be your excuse. Okay, so we're going to talk a little bit about that and what these people look to, what they look at, and some of the consequences of the actions they're going to face when I bring a case in front of a judge. So we have to remember to send this message and to make them aware of this. We have to remember a lot of people in our society don't ever go into a courtroom, ever. They don't get in trouble with the law, they don't understand penalties, they don't understand the consequences. Well, the consequences are there. The consequences are there for me, they're there for law enforcement officers, judges, representatives, 75-year-old people, my 88-year-old dad. Okay, they're all there. So let's talk about them a little bit. Because I'm a lawyer, I put my copyright notice up there. But please, if you feel that you want to use any part of my presentation, take it, use it, spread the message, because we want people to be aware. But please know this copyrighted information, it can only be used for educational purposes. End of that part of my lawyer talk. All right, I want to put numbers. You know, we've heard a lot about stats. 56 million people over the age of 65. Now, I'm creeping right up on Steve in terms of this age bracket. And this concerns me. This should concern all of us because of all the things that Dr. Matthews told us about their ability to drive, to operate that 3,000-pound missile on our streets. And I'm going to give you one soapbox moment from Joanne. I'm going to ask that all of us in this profession that deal with impaired drivers, whether it's prescription medication, whether it's marijuana, whether it's alcohol, polydrug use, anything, that we, as the professionals, as the message senders, never, ever, forever use the word accident. Because when you voluntarily choose to become impaired and sit behind the wheel of that missile, and you drive on my roads, where my granddaughter is, or my husband, or my family, okay, that's never an accident. It's a crash, it's a devastation, it's an explosion. It is whatever word you want to use to send that message. An accident is sliding on the black ice in your crazy winter you had up here, which I don't miss one bit, I'm just going to tell you that right now. But when you slide on the black ice and you take out your neighbor's mailbox, that's an accident. But not when you're a 0.15 blood alcohol concentration and you smoke 3 joints over the course of the afternoon and decide to go get your kid at soccer practice and wipe out the mother who's going to pick up your kid's school friend. Okay? Never an accident. All right, sorry. I get a little testy about that, as you can tell. All right. Just statistically, what we need to be aware of, I think, and these are stats that I use all the time, I'm specifically looking at 2013 here, where 13% of our 0.08 or higher blood alcohol concentration fatalities were someone 65 years or older. A 0.08, as we all know, is the illegal limit. It is the presumption of impairment across the United States of America. 13% of those are what's constituted as an older driver. And these are on the NHTSA website, the National Highway Traffic Safety Administration website. You can get a lot of this data. But this is good messaging. When you take this back to your communities and your groups, this is good messaging. They are killing people. And they always think, I'll never do that. That will never be me. It's the same message we have with our 17-year-old kids that are learning to drive. I'll never do it. It'll never be me. Until they do it and have to live with the consequences for the rest of their lives. All right, and here's some more data just from Massachusetts, just as an FYI. Again, driver involvement in fatal crashes by age group. 2012, last data I could find on the NHTSA website. Look at that. Look at those numbers. 449 people were killed by someone over the age of 65. 449 people, okay? They're the Matt Angelillos and they're the Caitlin Kozlowskis. Every one of those persons has a name and had a mother and a father and a friend and a cousin. Okay? We have to remember that too when we're messaging back to these people that are taking all these medications that Dr. Matthews was talking about. We have to send that back. These are people. These are our friends that are dying on the roads. Okay? My responsibility, and some people think I'm harsh. Okay? Maybe I am. I don't care. All right? I have a message to send, and it's my duty. It's my duty. I took an oath. I had to take an ethics exam. I had to take the bar exam. And I promised. I said, I will, I swear, I promise, uphold the laws of the state. Now, I'm licensed in the Commonwealth, and I'm also licensed in New York State. And I took that oath twice, okay, that I would do this, that I would do the right thing to the right person for the right reasons. And I have those statutory guidelines, and I have ethical considerations. And so do law enforcement officers. They take a similar ethical oath when they encounter an impaired driver on the road. These are not easy decisions that we make, all right? But these are our ethical obligations. And if people think I'm harsh, again, this is my job, and this is what I swore I would do to keep us safe. Public safety is part of my job, okay? So what are our goals? What's my goal? What's everybody's goal here, right? We want to prevent recidivism. Generally, when I'm seeing an impaired driver on the road, there are some statistics, and they vary, about how many times someone drives in an impaired condition before they get arrested. It's in the multiples. Some people go as high as 80 times, I've heard. I don't know how much I believe, but 80 times you drive impaired before you get arrested. Can you imagine if it's an older driver? Okay, how many times they may have been on the road? But I want to help to prevent that recidivism, and so do you. And we want to change that behavior. We need to message. But I also need to maintain the integrity of that case. Many of you may or may not know this, but oftentimes if you've been previously convicted of an impaired driving offense, and again, as Lieutenant Walsh said, age is not relevant here, we can enhance your charge because you got arrested again. So I need to maintain the integrity of that impaired driving operation that he made. And sometimes, yes, I have to think about now this person is 75. And how do we best deal with that conviction? Okay? These are just, and Steve talked a little bit about these, but just so you know what some of the penalties are. $5,000 and up to 2.5 years in prison. I'm telling you right here, right now, those are distinct possibilities for someone over the age of 65. People do go to jail, and they go to prison as a result of these. And that's the message we have to send. All right? And look at that fine. I don't know about you, but that's daunting, that amount of money. Okay? And here's the one for a vehicular homicide. Again, the penalties, up to 15 years if you kill that soccer mom waiting for her kid. Right? And this is one thing that Steve said, but I think it's really important to emphasize. This is one of the key cases in Massachusetts that talks about the burden, what we have to prove in court, that the driver may be found to have been under the influence when her consumption of such substances, and here's the key phrase, diminished her ability to operate a motor vehicle safely. Nice and vague, isn't it? Nice and vague. And that's why we rely, okay, on Officer Sutton from Norwell and Steve from Andover, that are out there making these assessments of these drivers. They're looking at everything head to toe to make an assumption of impairment. They will take into consideration age and their ability to perhaps perform field sobriety tests. But they're also going to talk to them and listen to them and look at them to make that assessment. Because when it comes to court, it's what they're going to tell our jurors about diminished capacity that's going to lead to a conviction. So our people that are taking all these drugs need to know that their abilities can be diminished to operate a motor vehicle. Did you see every time she put a list up there, there were like 5 things that affected operation of a motor vehicle with those drugs? And that's what our officers are going to be asking. What medications are you on, ma'am? What have you taken anything today, sir? Have you had any alcohol? All right? Okay. This is some of your licensing sanctions that can happen. If you tell an older driver they're going to lose their license, a lot of them have no other options. In the town of Norwell, my cousin Sue works at the Council on Aging. We don't have good transportation. In Norwell, we have no public transportation in Norwell. If you don't message to your older drivers that they could lose their license for 180 days or 3 years, that could cripple their existence. And as Steve said, yeah, are they going to have to eat cat food because they can't get out to the store? These are things they should know are potentials if they get behind the wheel in an impaired condition. All right, and this just kind of goes up the line. And you look how more and more and more they're going to lose their license, their operating privilege. And that's another thing we have to remind our older drivers. You have no right to a driver's license. It's a privilege to have a driver's license in the Commonwealth of Massachusetts. All right, and the state can say, I'm going to suspend you for a year. Oh, wait a minute. Once that year's up and you reapply, and they're like, you still on all those medications? You still being treated? You still doing all these things? Nah, we're not going to give it back to you. It's up to the DMV to decide if you get your license back. And a lot of people don't know that. We need to educate, especially our older drivers. Probably the last time they went to DMV other than to just grab their license was when they were 18. They don't remember any of that, okay? And this is, I'm going to just talk a little bit about marijuana. And I hate that word medical, hate it. I tend to use therapeutic, but I can't even in good conscience use that. But I'm not a legislator in the Commonwealth. I guess I'll have to use what they use. But what we have to remind our older drivers that do come into pain clinics or go and now want to get this medical marijuana, that gives them no license to drive impaired. Just because they've had a recommendation to go to a dispensary to get it doesn't mean they can smoke it and drive if they have diminished capacity, if they have that perception reaction problem, if they sit through 3 rounds of green lights because they're like, oh, I probably should have put my foot on the gas now, right? And I'm looking at all the cops just laughing because they've seen these people. But that's the other thing. That is enough. That gives you no permission. Okay? I want to just go through these terms just also very quickly, because a lot of the people that aren't in the law enforcement business or in the prosecution, they intermix these terms and they don't mean the same thing. And again, we need to message, right? So legalization, that's where they make possession and use legal under state law. Our Colorado, our Washington, now Alaska. Okay? Decriminalization, that has recently been done in Massachusetts, in some of the Atlantic states down around where I am, and they now decriminalize it, meaning they've reduced it from a crime to a civil offense. So as we all know, if you get arrested and convicted of a crime, from now on a job application, a school application, anything like that, they say, have you ever been convicted of a crime? Yes, I have. Now, with marijuana, if you get caught in possession, and under these new laws, under these decriminalization, it's now just a civil infraction. No, I have never been arrested for the crime of possession of marijuana, or a crime if this is the only time you've been arrested. It is no longer a criminal offense. And medical. And when there's a state that has a medical marijuana law on the books, medical, all that does is allow you to defend possession. Okay? It doesn't allow you to defend impaired operation. There's such a huge distinction. This is just a map. I know that Mary talked a little bit about it, about what states and what's happening. It's coming here, you know. You're going to be legalized one of these days, and whoever would have thought that. I certainly would have when I was a kid growing up here. But it's coming. It's coming to New England. And you've already, you know, it's medical, it's decriminalized, the next step is legalized. Okay. So here's what we do as prosecutors, all right? What I do, and I think what a lot of my colleagues do, certainly here in the Commonwealth, what we do is we try to take, if we have an older driver, remember, I'm trying to reduce recidivism, I'm trying to change behavior so we get these impaired drivers off the road. What I'm trying to do is I say, okay, how do we deal with this particular driver? Because I'm hoping you're all realizing that the age of cookie-cutter dispositions in court is over. We are looking at these as individual violators, and how best are we going to change that behavior and prevent them from doing it again. So I bring, we used to have DWI court days, and we would bring in our law enforcement officers, especially if they had vested interests in these cases. Our prosecutors, we had DWI courts set up to deal with some of these more repeat offenders to say, you need a little extra attention before we decide that you're okay to go back to driving. We bring in probation and parole. Because if I'm not going to send you to some kind of a correctional facility, whether it's a local jail, not I, the judge does that, but I recommend, if you're going to be sent to a correctional facility of some kind, I want parole to be on board to say, when that person gets out, that woman or that man, that 65-year-old person that took out that family of 5, they're going to have conditions. They're going to have conditions about treatment. They're going to have conditions about operation, places they can go and not go. So I want all these people to be on board and start talking to me about that 65-year-old woman. Tell me what I need to know about her so we can make the best assessment and we can put in place the best tools to do that. And so we also want to bring in DMV. I want to look at their license history. All right, they may be 65 with no priors, or they may be 65 and a speed demon and had 5 suspensions of their license before because of speed violations. So I want to do that. And then I want to bring in the treatment professionals, because I'm not one. All right, I knew a lot of those drugs just because I've been doing these cases a long time, but I didn't know all this stuff. And that could affect how we want to formulate a disposition and what's effective. But we have to work together. I can't do that all by myself. All right, I can't do it without my cops. I can't do it without my treatment providers. So we all need to do an assessment of what's going to be right for this older driver. And again, this is what you got to be talking to your people about. All right? I just wanted to put this up there. We had an organization in New York called Stop DWI. And we did an assessment kind of around the state as to what the average expenses were for an impaired driving offense. I know there's a lot of info up there on this slide, and the numbers can vary a little bit. But for your first offense of DWI, and that's what we called it in New York, OUI here in Mass, but you're just going to spend cost-wise. So now you have the charge, you have the other punishments. Now it's just money. This is all going to happen regardless of if you go into a correctional facility or not. Upwards of $9,000 to $10,000, depending on the nature and extent of your charge. Okay, $10,000, and that's not even, all the hell you're going to have to deal with, or your people are going to have to deal with and live with for the rest of their lives. That's out of pocket. Huge amount of money. Okay? These are some really good resources. I'm a fast talker anyway, but I am really motoring right now. These are some good resources out there. Most of them are on the NHTSA website. There's some amazing researchers at the National Highway Traffic Safety Administration. Again, this is all on our information. Some great websites, the whitehouse.gov, the Office of the National Drug Control Policy has a whole area on their website dedicated to drug-impaired driving. It's one of the president's national agenda points. They have a ton of information that may be useful for you to download, as well as some of this NHTSA material to hand out if you have a seminar with your organization or you have a community teaching event. Spread the word about the dangers, not only of just being old, but being old where you're drinking and you're taking drugs. Remember, the marijuana and the marijuana these people are taking, it's not the marijuana of the 70s. We're not talking like a 3% THC. We're up to what, 17, 20, 30% tetrahydrocannabinol, the active ingredient of marijuana. It's not what everybody might have smoked in college 20, 25 years ago. It is an entirely different mindset when you smoke that marijuana. And we don't have all the studies that we need yet. Okay? We don't want that. I used to go to crash scenes. I went to that crash scene. Okay, we don't want that. We lost an elderly woman in the back seat, severed aorta, died instantaneously. Husband in the passenger seat killed. Woman in the front, thank the good Lord, has eventually survived, but 12 years later still has surgeries on her feet because they were crushed, because she got hit by an impaired driver. Age is irrelevant, okay, when that person gets behind the wheel. And we need to send that message. Any questions? Mary, I talked as fast as I humanly could, gal. All right, thank you, everybody.
Thank you, Joanne, for a terrific and eye-opening presentations, 3 terrific eye-opening presentations. I wish we had more time. I apologize for that. I will tell you that they have to take this wall down, so I'm literally standing in the way of you and lunch. But I would say that our 3 speakers are more than happy to chat with you now or on the way into lunch, certainly. And once again, let's give them a round of applause for 3 great presentations.